And now it's time for our special general session panel about diabetes and mental health. Our session is moderated by Mary DeGroot, Associate Professor of Medicine and Acting Director of the Diabetes Translational Research Center at Indiana University. Mary's panelists are Elizabeth Beverly, an Assistant Professor at Ohio University, Michelle Lichman, an Assistant Professor and Nurse Practitioner at the University of Utah College of Nursing, and Anna Norton, the CEO of Diabetes Sisters. Please welcome Mary and her panel to the stage.
Good morning, everyone. It's our pleasure to be before you this morning to talk about peer support communities improving mental health for people with diabetes. And our goal here today with our esteemed panel is to talk about it and to share with you some thoughts and variety of different experiences related to peer support and mental health. These are our disclosures. And so we'll be talking, I'll spend a few minutes here framing our conversation about models of peer support and definitions of peer support. I'll talk briefly about the benefits, and then most of our time will be spent talking from our lived experience of working with people with diabetes and communities of peer support and diabetes education. So let's first start with the definition of peer support. So as you know from all of the different offerings that have been held through AADE 18 this year, peer support can be defined in a variety of ways, and we're really broadening our definition here in this session. As Ed Fisher and colleagues wrote in a systematic review published just last year in 2017, the definition of peer support can include emotional, motivational, and practical assistance provided by non-professionals for complex health behaviors. And certainly when we think of diabetes, we know that we have many complex health behaviors involved. It also involves the linkage to clinical care and community resources and ongoing availability to address chronic conditions. And peer support for the person with diabetes occurs within the larger context of family, community, healthcare, and national infrastructure. And the model that I like to think about peer support involved in is one that's very, I think, common to most of us, which is the social ecological model. And in this model, we have the person in the center, the individual in the center, the person with diabetes. And then the outer ring there, the next ring is family, friends, and peer support, followed by organizations, communities, and culture. And then in the outermost ring, we think about those policies and structures that provide us with practice guidelines at the organizational, national, and perhaps even international level. And so when we think about peer support, we're using one term, but really we have many different examples that we'll talk about today. That can include peer support from family members, spouses, and extended family. It can involve models that involve community health workers or promotores de salud, patient navigator systems, peer support networks, and technological connections that bring people together, such as social media, telephone-based support, and internet forums and blogs. And so the question that has been asked is, does peer support contribute to outcomes for people with diabetes? Spoiler alert, the answer is yes, it does, actually. And in a systematic review that was, again, published by Ed Fisher and colleagues in 2017, was a review of 65 studies published in the new millennium, between 2000 and 2015. And among the studies that focused on diabetes outcomes, which were 30 of those studies, 86.7% of those reported significant positive impacts of peer support. They found that the average improvement in A1C across these trials was an improvement of 0.76%, which, as we know, is clinically meaningful, and that peer support was cost effective. It involved reductions in emergency care, hospitalizations, and Medicaid costs. We also know that positive peer support contributes to positive psychosocial outcomes of diabetes. It involves improvements in increased quality of life, decreased diabetes-related distress, as demonstrated across the full spectrum of types of peer support, ranging from peer support at camps to college students receiving peer support through the College Diabetes Network, and as well as adults. And it also positively can contribute to improved diabetes self-management. So then if we think about peer support, then going back to our social ecological model, and we think about that outer layer now in red, of health policies and practice guidelines, what do we have in terms of guidelines and support for those of us who are in healthcare to help us make good use of peer support? And the good news is we have quite a bit, actually, to support us. The American Diabetes Association, both in the position statement on the psychosocial care of people with diabetes and in the standards of medical care in diabetes, have focused on patient-centered care as a core general standard and have explicit recommendations for the use of peer support, community health workers, and so forth. There are provisions that are included in the U.S. Affordable Care Act, as well as the World Health Organization Global Health Workforce Alliance. And perhaps most specific here and most relevant are two initiatives from the AADE. Peer support was included in the AADE 2017 National Standards for Diabetes Self-Management and Education Support, and that document is available as published by Beck and colleagues. And this year and moving forward has been the AADE and Peer Support Communities Initiative, for what is responsible for much of the programming around peer support at this year's event. We also have guidelines from the Peers for Progress organization for the international dissemination of best practices from which we can draw. And on a practical level, and I'm always interested in the practical piece, there is a tip sheet. And so if you are not already familiar with this, you may want to go to the AADE website, diabeteseducator.org, and find the AADE Peer Support tip sheet under Learn, Connect, and Engage. So now I will transition and we'll have a conversation with our esteemed panel. As already introduced, we're joined by Michelle Lichtman, who's on faculty at the University of Utah School of Nursing, Elizabeth Beverly, on faculty at the Ohio University Heritage College of Osteopathic Medicine, and Anna Norton with Diabetes Sisters. Please help me welcome them. So let's begin our conversation by having you each introduce yourselves and the nature of the work that you do. Liz, do you want to go first?
Sure. My name's Liz Beverly. As Mary said, I'm an assistant professor of family medicine at the Ohio University Heritage College of Osteopathic Medicine. I'm a diabetes researcher, and I focus on the psychosocial factors to managing diabetes. I've been in rural southeastern Ohio for about 5 years now, and previously I was at the Joslin Diabetes Center where I did a lot of my training. Transitioning from Boston to southeastern Ohio was quite the transition, if anybody knows anything about the region. And I was very fortunate when I got to that area that there was a new program that they were starting, which was diabetes patient navigation. And they were actually looking for someone to take over those programs. And so, of course, I raised my hand and said, I'll do it. So I jumped up aboard that and said I would happily learn about patient navigation and run those programs. So I do a lot of patient navigation, and that's with registered nurses as well as community health workers. And so that's a lot of the research that I'm focusing on in that area.
Great. Michelle.
Hi, I'm Michelle Lichtman. I am an assistant professor at the University of Utah. I've been a nurse practitioner for 12 years, always focused in diabetes space, And a few years ago, I decided to explore the research space of diabetes. My experience is, as a nurse practitioner, I've conducted shared medical visits for individuals with type 1 diabetes and also type 2 diabetes. I've also developed a Diabetes One Day Education and Care Program, which is an interdisciplinary program that involves patients, their care partners, and also in-group and individual sessions that last one day. And then also, my research space focuses on the social context of diabetes, which might include individuals with diabetes and their romantic partners, individuals with diabetes and their parents, and then also how individuals are using technology such as social media to support their diabetes care.
Anna.
Hi, good morning, everyone. My name is Anna Norton, and I have been living with type 1 diabetes for 25 years. I am also the CEO of Diabetes Sisters, as Mary mentioned, and Diabetes Sisters is a national nonprofit organization whose mission is to support and educate women living with any kind of diabetes. We're all inclusive. We do a lot of programming online and in person to better support women that live with diabetes and their caregivers. We have a signature program that focuses on peer support communities in 23 states in the United States right now, in 35 different locations where peer leaders are leading those groups and working with women to better live with diabetes.
Great. So I'll ask everyone this question, but Anna, staying with you for a moment, what inspired you to do the work that you do in Diabetes Sisters?
So I lived with diabetes very isolated for many, many years, and about 7 years ago, I came upon Diabetes Sisters and selfishly attended a conference because I wanted to learn from other women. I wanted to be inspired, and I wanted to live the best life that I could. My son was 2 years old, and all I could think about was, I don't want to see him when he's 2, I want to see him when he's 22, and I want to see him when he's 42. So I went to this conference very selfishly, thinking, what can I get out of it? What can I get out of it? And I got so much out of that. But before the weekend ended, I met women that were younger than me, that had been living with diabetes for less time than me, who asked me so many questions and said to me before we left for the weekend, you really inspired me, Anna. I didn't know that I could do this. And for me, that pulled away a different layer. And it made diabetes much more deeper than me, and I realized that I could affect change in the way that women lived with diabetes, and that we could really support each other. And that transformation to me was really paramount.
That's great. Michelle, how about you? What's inspired you?
So what inspired me was early in my career as a nurse practitioner, I had 2 19-year-old patients, both living with type 1 diabetes, and they both wanted to meet another person with diabetes who was about the same age. Neither one of them had been to camp. And through HIPAA, I couldn't connect them. And so we decided, some clinicians in the clinic and I, we decided to throw what we call a diabetes mixer. It was a social event. It was not an education event, a social event that had live music. It was at a restaurant. We had fun food. We worked with the chef to work on carb counts for everything. There were prizes. And through that, people were able to connect, not just the 2, but everybody in, we invited as many people as we could in Utah. And what started out as a 40-person event has now turned into a 200-person event over the last 6 years. So we're really excited about that.
Fantastic. Okay. How about you, Liz? What's inspires you to do the work you do in rural Appalachia?
Well, part of it is what inspires me is how I even got into diabetes. And I kind of fell into it by accident. I went to graduate school to study Alzheimer's. And of course, my graduate advisor got a grant in diabetes and said, well, you're not doing Alzheimer's for the next 4 years, you're doing diabetes. And I said, okay. And so with that,
Adaptive.
yes, so I wanted my degree, so I did diabetes. And with that first study, it was a qualitative study, and I fell in love with qualitative research. And listening to the patient stories, I realized there was something I could do. And I have now been doing qualitative research in diabetes for 14 years. And I realized I can make a difference by hearing patient stories and telling patient stories. And so that is what I do for a living. I share the truth about what patients are going through. And in rural Appalachia, it is an area that has not received enough attention. And it's kind of been ignored, I would say. And then the only work that's actually been done in that region happens to be the work that you did while you were there. And we need to focus more attention on what's happening in that region. So I'm trying to give more attention there.
So a sense of connection to the community,
Yeah.
a sense of wanting to make a difference, kind of growing where you're planted.
Yes.
Yes, yeah, I share that. I believe that too. So let me open this up to our group here. So the work that we do is varied. It's wonderful and not particularly easy. What kinds of barriers have you had to overcome in order to be successful in creating the kinds of programs that we have represented here? Whoever would like to go first.
Sure, I'll start since I just talked about rural Appalachia.
Sure.
I don't know if we have people in the audience here who are part of rural Appalachia or part of rural communities. Okay?
Oh.
So for me, coming to that region, it was exposure to different barriers than I'm used to when I was in Boston, which was an urban community. So a lot of the barriers that I'm faced with in that region are practical barriers. So we're in a rural region. Transportation's a big issue. So doing patient navigation, and we even have peer support communities as well. Transportation's a huge issue. Poverty is a big, big challenge. The county that I'm in, Athens County, is the poorest county in the state of Ohio with a 33% poverty rate. So dealing with poverty is a big issue, and that's why we have patient navigation, to address those barriers. So a lot of the things that we encounter in terms of barriers in trying to help is we are trying to focus on those health disparities, and that's the biggest challenge, and we're hoping to use peer support as well as patient navigation to address those health disparities.
Great.
I think some of the challenges that I have faced is trying to get patients to see the value in some of the group sessions. So I think that some people don't realize that they need the support until they get it, but it's really trying to get them to see that they need it before they understand they need it in some ways. And so sometimes it's nice to talk about what will be discussed in the group sessions that we run. And I think what has been really nice is we really encourage people to bring care partners. So we know that the person with diabetes may not be the one who's doing the cooking or the grocery shopping or, maybe even the lead of the family, and there's some instances in which that happens. And so I think that it's really critical to involve the care partners, and those care partners could be children of elderly patients, it could be a spouse, and I've even seen patients bring their parents or even siblings. And so I think that sometimes we forget the social context of diabetes, and it can be challenging because a lot of people work, and so making sure that we offer our programs during times that are accessible. So we used to do evening shared medical appointments, and right now, instead of a 6-week series, we've crammed everything into one day, so people only need to take one day off work.
At Diabetes Sisters, one of our biggest challenges is the recruitment of women to come to the peer support groups. We have over 50 key volunteers all over the country who all have diabetes, but sometimes struggle to get women to come to their meetups. And that's really difficult, and it's it can take away some of the motivation of wanting to do it. But so we are out in the community. We train our volunteers. We try to provide them as much guidance and leadership and support as we possibly can. And another thing is sometimes we have our meetups skew in one direction more than another, and I think that's because diabetes has so much stigma. Some of the women don't want to come because they say, I don't want to go to a support group. I don't need any support. And like Michelle said, sometimes we don't realize that we need support until we're actually in that moment, and then we realize, wow, that's exactly what I needed. And so that's a struggle and a challenge that we face, to get the women to come to sort of think, you know what, it doesn't matter that I have diabetes. These women also have diabetes, and I can speak freely about that, and they're not going to judge me. And so we're slowly overcoming that. And the last challenge that we have is women of color, underserved populations, Hispanic, Latina women, African American women. And so we have a program that we're going back into the community and reaching those women in a very culturally sensitive way, speaking to them in their language. And those programs grow slowly, but they grow. And that's where groups like this really help us to grow them and identify patients, people with diabetes, their caregivers, to come and learn more and then better support one another.
Well, and if I could piggyback off of what Anna said, I think that women who have children are very challenging to recruit, because if they're caregiving for their children and you don't offer daycare services, I've been asked multiple times with our one-day program, you know, do you have childcare? Can you do anything about that? And that's something that we're actively looking into. We've talked to some of the directors higher up in the system to see if that might be a possibility. So thinking about those accommodations that we need to provide patients so that they can actually get the care they need if you're going to be providing a service all day.
So let's talk a little bit more about stigma. So thank you, Anna, for raising that, because that's an important piece, right? We have stigma in many different ways. It cross-cuts many different ways. We have stigma associated with diabetes. We have stigma associated with some of the stress and distress and mental health issues that can go hand in hand with diabetes. What have you seen in terms of stigma in the Appalachian region, Liz?
So there's a lot of stigma in the rural Appalachian region. There's a lot of mental health issues. We know diabetes is associated with a lot of mental health issues. You gave a wonderful talk on that yesterday. And there's a bidirectional relationship. And in terms of the navigation that we're doing, the navigation as a model is not necessarily designed to address the mental health issues. So what we're having to do, that is by far the biggest barrier that we've experienced. And so we're having to work around it, and some of the programming that we're doing next is we're including additional services for mental health so that we can address the mental health, because by far that is the biggest issue. And the navigators themselves are not equipped to address the mental health. And for those of you who might be from that region, you know that we do not have, it's a health shortage, so we do not have the mental health providers in that region. So we have a shortage. We have an abundance of mental health crises in that region, and we're trying to do, with all the other health disparities, we're not able to address it. So not only is it a major barrier for diabetes, we are also having a mental health crisis, and the navigators can't do this. So it's a kind of the perfect storm that's happening with this. So we're fortunate, we just got grant funded, and because we have a university, we actually have a teaching clinic. So we are able to provide free mental health visits to those patients so that we can refer. And it's making the navigation much more efficient now that we can just refer those individuals to the free mental health services. It's also very difficult, though, because there's a lot of stigma with mental health, and we're having to be very creative about how we talk to the individuals about the mental health, and just say that, you know, this is behavioral health, this is an important component. It's very important for your diabetes that we talk about some of these issues. And I'm sure we can also talk about with, you know, the clinicians on this panel, how we can, other strategies for how we talk about it with our patients. But it's a very big struggle with the stigma associated with mental health.
And I think that's challenging in sometimes recruiting patients to peer support groups or group visits, because some people want to keep their diabetes private and they don't want other people to know they have diabetes or some of the concerns or problems that they face. And so that's definitely a challenge. In the online peer support community, we have seen that it tends to skew more towards type 1 diabetes, which, as we know, takes up a smaller percentage of the general diabetes population. And so we're not quite sure why that could be true. You know, I have some of my own assumptions in that it's easier to connect with someone with type 2, perhaps in the real world, than maybe with someone with type 1 diabetes, and so that might be one reason. But there have been 2 studies that have indicated that there are sometimes disagreements between those with type 1 and type 2 in the online space, and I think that should be acknowledged. And we need to make sure that we're sending our patients to safe spaces. So if you're considering online support, I want you to make sure that you're vetting the community yourself. I know that AADE has put out some great resources, and there's plenty of others as well. I think it's just really critical that you take a look at those resources yourself and make sure that you feel comfortable sending your patients there. That's what I do. And I also think that there's some new emerging research done by Kelly Rawlings that suggests that there are some hashtags that might be more stigmatizing than others. And so we need to pay attention to that. So we know that the millennial generation and likely Gen Z is more likely to skew towards using hashtags in an online support community. So that would be Twitter and Instagram. And so we need to look at those hashtags and see what we see if we think that people are going to be getting the support they need when they use that type of support.
Absolutely. And just to piggyback on what Michelle's talking about, I think it's very similar even in in-person peer support communities. There's a lot of stigma. I mean, I mentioned that in our in-person support groups, we have we skew more toward type 1 also. And we make all of our meetups very inclusive. As a matter of fact, our materials just say diabetes, because we want people to feel comfortable saying, I have diabetes. It doesn't matter the type. One of the things that we talk about all the time is, as people with diabetes, not just women, our ultimate goal is really to try to maintain our range A1C, a range glucose number, right? So it doesn't matter if we have type 1 or type 2. That's our goal, right? To have a nice flat CGM line, right? That's what I always say. But we're at the same risk for everything. We're all at risk for kidney disease and heart disease and mental illness and depression. And so from the diabetes standpoint, it's really our responsibility to say we all share this common chronic illness. It doesn't matter the type, right? Even if you have prediabetes, it doesn't matter. These are the goals. These are the things that we want to do to make sure that you're living a full life, that you're living victoriously despite diabetes.
So one of the things we were talking about yesterday was about, kind of to your point about vetting. So Michelle, I love that point about making sure that, and this would be true for any other resource that we refer patients to, right? And we would refer them to a book. We really should take a look at that book before we make that referral. And so the online space makes a lot of sense there. We were talking a little bit yesterday, Anna, about the kinds of preparation that goes into the peer leaders, that the model that you use in Diabetes Sisters. Do you want to share a little bit about that?
Yeah, absolutely. So, like I mentioned, we have over 50 key volunteers that are unpaid volunteers. They are the bloodline of Diabetes Sisters because they represent the organization nationwide, right? I live in one state. We have a staff member that lives in another state, but we have these 50 plus women that live all over the country. So once a year, we invite them to a leadership institute. It's funded by some of our industry partners, which is wonderful. And we're able to provide 2.5 days of more training, more development, and then among the leaders themselves, peer support. So the leaders need the support as well. So when they come together as a group, they can chat with one another, not only about their leadership styles, but about their own management. So they can feed off of each other, they can get advice from one another, and they walk out sort of with that same motivation and inspiration. We also get them on the phone. We do conference calls 4 times a year with them, and then monthly emails. So we have a very, very open line of communication with them and try to provide them as much information throughout the year as possible. One of the other things that we provide them annually at our institute is more education. So we phrase it as we're going to talk about the sexy topic. What's the sexy topic? Is it intimacy? Is it mental health? And so that provides them the opportunity to learn more about how to manage their own diabetes and then bring it back to the community and the peer support group.
Right. So we've talked some about stigma, we've talked some about barriers. Let's talk about some of the benefits. We do this and we succeed at this for a reason. What are some of the ways that you've seen peer support improve mental health outcomes in the people you work with?
Well, I mean, I mentioned that 7 or 8 years ago I attended my first Diabetes Sisters event, and I did not realize how lonely I was and how isolated I was. I thought I had all the support that I needed within the 4 walls of my house. But my husband doesn't have diabetes, my son doesn't have diabetes, my mother doesn't, my father now has type 2 diabetes, but I was very, very alone in my journey. And so I learned to live that way, and I learned to live well that way with diabetes, but it wasn't until this peer support component came into my life where I thought, I feel like my shoulders can come down now. And I saw that among so many other women. And I saw an instant connection because of the diabetes, but the connections remain because of so many other things that we share, whether it's motherhood or work life balance or the love of travel, lots of different things that really are the thread that weaves us together ultimately, to form true sisterhood, true friendship. And we have seen that with so many of our community, so many women in the community that are texting each other from, the West Coast to the East Coast, right? That use each other for accountability, that do Fitbit walking wars every week. So it really does improve physical well-being, mental well-being, and diabetes management, because there is an accountability, there's this another level of understanding and empowerment and self-advocacy. And I think that's very, very important in order for us to live 24 hours a day, 7 days a week, 52 weeks a year.
And I think if you want to look at the evidence in online peer support communities, a team and I just conducted a scoping review, which essentially maps all of the research in a specific space. And if you look at peer-to-peer online community support, the psychosocial factors, the mental health factors that are really coming through in the literature is, number one is shared experience. So through shared experience, people have this sense of normalcy where they can identify themselves in another person. And I think that is so critical. Another thing is there's social support, and social support can come in many levels. It can be that emotional support. It can be tangible support. People can connect people with resources. So there's just so many components to this. There's so many layers to the level of support that can be provided. I think that when you look at the quality of information, there were 5 studies that looked specifically at misinformation in online peer-to-peer communities, and those ranged from 0 to 9%. And if you think about where did that 9% come from, these were in online forums and also in blogs. And it's interesting that the parent post, so the parent blog or the parent posted an online forum, the misinformation rate was very, very, very low. It was sometimes in the comments where we would see a little bit of misinformation, but all of the reviewers also noted that they didn't think that this would significantly sway somebody to make a bad decision about their diabetes. And so I think that's also important to note as well. So it didn't seem like there was this significant harm that was coming from it. And when you look at harm specifically, so in 2 studies, people were asked, have you or anyone you know in an online community specific to diabetes been harmed related to diabetes? And it ranged from 0.7 to 1.8%, very, very low numbers. And if you look at help, it was much greater in the 70 percentile. And so I think that we need to consider how these communities could really help somebody. And when I talked about earlier vetting the community, I wasn't meaning vetting the community for information. It was more vetting for stigma. And so I just want to make sure that that's really clear. And then from a clinical standpoint, the peer support programs that we run, I think that one of the values we see, not just the patients connecting, but also the care partners. And so I have seen wives of people with diabetes kind of gather together in the hall and exchange phone numbers, and they get each other. And so I think that sometimes we forget the family members that are affected by diabetes. And so I think that peer support could really be helpful in that space as well.
Mm-hmm. And if I can just add to that, Michelle, I love that you brought up partners and caregivers. Mm-hmm. So one of the programs that Diabetes Sisters offers when we have a big annual meeting is a partner's perspective program. And so we do bring in experts to have conversations with the caregivers about diabetes, but then we have some psychologists that come in and talk about their fears, their emotions, and what are they experiencing. And a lot of the surveys come back and say, again, I didn't know that I needed this. I never speak, but I met someone else who is worried about a low in the middle of the night, or is worried about quality of life for their girlfriend or their wife. And so I didn't realize that I needed this, but I need it too. Or now I understand what a high is. Now I understand what a low blood sugar is. Now I know how to inject glucagon. I didn't know how to do that in the past. So we really focus on providing more tools for the partners, the physical tools, but also the emotional ones as well, so that they don't feel as isolated too, because oftentimes they don't want to share with the person with diabetes I'm scared for you, I'm worried about you, I don't like to see you in this manner, things like that. So that's very, very important too, because diabetes can cause burnout not only in the patient, but in everyone around them.
Absolutely, absolutely, yeah. Liz, what have you observed in terms of the work that you do and the positive effects of peer support?
Sure. In the patient navigation literature, patient navigation from lay health workers, community health workers, as well as registered nurses, it does show that it can improve A1C, which is fantastic. It improves self-care. And in terms of the emotional well-being, it does improve diabetes quality of life. Some of the work that I'm doing right now, I'm very interested in the psychosocial factors, so I look at depression and I look at diabetes distress, and I have preliminary evidence that it shows that the nurse navigation, the community health workers, it can improve those measures, which is what we're looking at. Even though navigation, again, is not providing direct clinical care, you're just addressing the barriers into the healthcare system and reducing those barriers. So that's a fantastic finding that we're going to be showing that soon. So seeing that, but I think what navigation is providing is, in between seeing the healthcare visits, what you're seeing is the constant follow-up. A patient has someone to go to, right? So you have, and what we're doing is from our endocrine center, we have the CDE can refer the navigator, you can have the nurse practitioner can refer to the navigator, and the endocrinologist, diabetologist can refer. So you have this person who's a constant connection for that patient. And so we're reducing hospital stays, emergency department visits, which is great. So we're reducing costs. But that individual has someone who can call, someone that they can email or text if they need to. So they have almost an emotional support person, which is so critical for diabetes.
And I think that's true for the online space as well. So it could be midnight and you need to reach out to somebody. You can't call your clinician, maybe your family members are asleep, but it's a different time zone somewhere else in the rest of the world. And so you can connect. It's a 24/7 low cost resource that people can use. And so I think that that's really critical. And the outcome measures that Liz just mentioned, quality of life, self-care, and A1C, those have also been shown to be great outcome measures in online peer support communities for diabetes as well.
And if I was going to add something, so this might be hard to believe, but in rural Appalachia, the online email stuff really doesn't happen.
Yeah.
There's a lot of areas in that region that still do not have the internet. So it's kind of a different world. Like, we don't even have Uber. So I don't even know how to Uber because I've been so far out of the city, so I don't even know how that works. So navigation is working. So a lot of things are done by phone and fax, and so the online communities and the peer support is fantastic, but for certain places in rural Appalachia, it's just not possible. I mean, we do have Facebook, and but for some individuals, they don't have access to the internet, so it's just not feasible. So the navigation is the path that we're using because it's just not doable.
Yeah. And since we do both online and in-person support, we kind of cater to the audience. So we know that in our underserved communities, Facebook, Twitter, Instagram, that's not going to work. So that's why we've gone back to the actual communities and said, what do you need and how can we provide it? With our leadership, with our key leaders, we do a lot of the technology to talk with them. When we can't see them physically, they all have Facebook pages, we have private pages. There's a lot of resource sharing there among the members and the leaders. So those things are important too, and so we try to cater to the different age groups, to the different locations and the different needs of the community.
So I think that's a really nice point, that there are many different models that you can utilize peer support, that will be tailored from person to person, depending on their interests, their generational cohort, their resource access. And then I'm also hearing themes of empowerment, which is a theme near and dear to diabetes educators' hearts, about patient empowerment, and also accountability. That with peer support comes that emotional support, the tangible support, the intangible support, but also the accountability piece of somebody knows me. Somebody, if I make a pledge to someone, they're probably going to ask me about that later, and that feels supportive when that's well carried out. Would you agree? So let's turn our conversation to the role that diabetes educators can play in facilitating peer support. What can diabetes educators do to help to help that process along?
I'll jump in.
We have a few here.
Yeah.
Sorry.
So the part of the region I'm in, rural Appalachia has a very distinct culture. It's very much rooted in family. And you're in or you're out. And I'm definitely an outsider coming in, and people know right from the get-go that I'm an outsider. And the thing for the certified diabetes educator that we have in the community is love. Everybody knows her and loves her and trusts her. And so we've actually started we have a Diabetes Community Partners, which is our own peer support group that was community member driven. And we've just started one with our University for the College students. And our certified diabetes educator, because she has so much trust within the community, what we have been doing is going to the CDE and saying, hey, could you tell individuals that you think would be great for this peer-to-peer group? Could you recommend individuals? And that's how we're getting our buy-in, because everyone trusts our CDE and loves our CDE. And that's how we're getting members referred to our community group. If Karen approves, they will join. And that's how we get our buy-in, because we have our physicians, and because rural Appalachia is all about family and the family unit. So they see Karen as part of their family because they love Karen. And because Karen has helped them manage their disease, they trust her. And so if Karen is a part of the family and Karen believes that we are helpful, so she's the gatekeeper. And if she approves, then they will do it. So that is how critical and how important our CD is to our success for the navigation as well as for our own peer support groups.
Okay.
Yeah, I'd love to say that. I mean, online, we work with a multitude of educators that provide us content for our website, really valuable, trusted information. And so we feature those CDEs every month. In person, when we have our conferences, when we have our institutes, we'll bring CDs, sometimes to standing room only, facilities, because they're so trusted, they're so personable, they have such a wealth of information, and they share it freely and readily. And that's so important for patients to be validated in what they're doing on a day-to-day basis, and that an educator will say, like, yeah, right on. That's great, or that they're providing up-to-date information, relevant information. They're not just talking about A1C. They're talking about, let's talk about your life. How do we adjust your life, or how do we adjust diabetes to your life?
Yeah.
Right, and that's also very important. So when we work with educators, we always say this is the audience, and we again try to match educators with the community and their needs. So we have, and she might be sitting out here. We have an educator who has been requested for our Spanish-speaking program multiple times because the community trusts her. They feel comfortable with her and they want to see her. So we try to provide that. Other educators, like I said, standing room only. We have to say, like, there's no more seats. Sorry. And then when we're finished or they're finished with their sessions, they get bombarded. And that says a lot about what an educator can do and the power that educators have to really transform the way that patients live their lives every day.
So educators are really welcomed and are really needed for the expertise they bring. Michelle, what are your thoughts?
I definitely agree with that. I think that in the online peer support communities, there have been some communities that were initially organically grown as patient communities, but educators have been welcomed. And I think that really shows a lot about the value of diabetes educators. I think that if I was going to give some recommendations, it would be that know your resources and grow your resources. So with that, are there things that you could be doing that could incorporate a peer support component? If you're going to be offering education, is there a way to also offer a support component to that, where individuals can have a social that doesn't just revolve around education, where they can actually meet and discuss their own issues or concerns or successes even? And so I think that that's really critical. We know from the National Practice Survey that 1/3 of diabetes educators are actually recommending the online community in some way, so that's amazing. I hope that continues to grow. And more than that, are actually lurking. So what that means is people are kind of going online, looking to see what people are talking about. And it's been really interesting. I went to dinner with a couple diabetes educators the other day, and they were really intrigued by the Dexcom or the CGM or pump rash sites, because they wanted to be able to help their own patients with concerns about different rashes and adhesive irritation issues. And so sometimes you can actually look at what are other patients doing and what's been successful, and try to find ways to help patients in that way. And then for me personally, because I have done some of my own look at the community, I know specific people that I want to connect them to, because I think that they have a shared experience. And so I don't think that you have to invest a ton of time, but I think that it's worth investing some time so that you can actually connect people to the right resource.
And if I could add something about the patient navigation piece. Patient navigation, again, a navigator's not providing clinical care. And in terms of education, they're only reinforcing what the educator's providing. And that's coming from the context of if it's a nurse navigator. So the nurse navigator is just reinforcing what the navigator provided as a part of the plan. If it's a community health worker is most likely not going to be reinforcing the education unless they receive some form of education during the training. So it's really important that plans are provided as part of the navigation protocol. That at least that's what we're doing for our nurse navigation with the diabetes, is that we just reinforce the education from the CDE.
Okay. So what is one thing that you'd like diabetes educators to know that would make your work easier?
Well, that we're here, that organizations like Diabetes Sisters exist, right? And that we're really here to make it easier for you. We're here to make it easier. We're not here to replace educators. We're here to enhance the work that you do. We're here to take some of that burden off of you so that you can help and see in more people with diabetes. The referral thing is the biggest compliment that you could give any patient organization that's vetted and reputable, because it gives us more work to do, and it gives us the opportunity to affect more change. Right? And it gives us the opportunity to erase more stigma or to educate one more person. So I think that it's imperative that you understand that you see that, that we're here to work with you. I know AADE has been doing wonderful things with peer support communities and the patient groups. We've been working together for almost a year to really help AADE grow in that aspect, and to help us as patient organizations grow and provide more reputable resources and information. So know that we're here. Know that you can reach out to us. Many patient organizations, we're run by very small staff, but this is our calling. This is our duty, both to ourselves and to our community. So know that and use us. Please use us.
And I think that nobody needs to reinvent the wheel. I mean, we all think that, innovation is great, but also looking at what has been successful and replicating that is just as good. And so I think that looking at programs that have been successful, how did you get these, in rural areas, how do you get that program going? I think that it's really critical to look at how programs that you want to see in your own area, look to see what else has been done, see how you can make it fit for your community. Our one-day program was mimicked from a 3-day program. And then we decided for our community, we just need to make it a one-day program so that people will come. And so, we're not developing things without looking at other resources. And I think that we all need to be willing to share with each other. There should be no trade secrets in healthcare. We should all be willing to share, because the ultimate goal is helping patients.
And all I would add is the programs that I'm a part of wouldn't exist without the CDE. The CDE is integral. And again, considering the tight-knit community of rural Appalachia, if we did not have our CDE and her support, we wouldn't have our programs. That's how critical our CDE is. And I also think that the patient navigation, as well as some of the peer support groups, they're there to support the CDE. We're trying to address and reduce some of those barriers so that the CDE has more time to really focus on the education. Because if we can reduce some of the barriers, there are fewer things that the patient has to worry about, and then they have more time to actually dedicate to their diabetes.
Yeah. So we have a theme about peer support being empowering to people who make use of that. I'm also hearing a theme of empowering diabetes educators. And certainly from my perspective, when I think about diabetes land, as I like to call it, all of us involved in diabetes one way or another, people with diabetes, family members, healthcare, and everyone involved, I think about diabetes educators as being in the center of that world from the standpoint of being the linkage of many different resources. And that those resources then also support the work of the educator. I would add in one thing we haven't really talked about, and that is the role of research. We've cited research, and we have an emerging literature, better than emerging, because we have many studies now that have been done, and Michelle, you've quoted a number of those, and you do a number of those yourself, as does Liz and myself. And so I would add to that mix of the role that diabetes education can play in supporting research. One of the things that I've observed in my area in the Midwest has been really a diffusion of attention, right? We have so many things that we're now scheduled to do, and that we have so many pulls for our attention, and so many devices that pull our attention to them. That some of those more traditional ways of scheduling a research interview or participating in a study can be, we have more distractions now. People may want to do that, but they have many other dings and pulls and buzzing going on in their lives to take them to other places. And so really integration of research. In my own institution, we're currently doing a study funded by the IU Health System on a diabetes tune-up group. And we're partnering, diabetes educators are partnering with clinical health psychology trainees to deliver a psychoeducation group around adherence support and diabetes-related distress. And our diabetes educators are terrific. They're in the center of everything there in that program, including the outreach to patients. So the ability to touch patients and to make all of the aspects of what we do relevant, including research. Any thoughts that you'd want to share along those lines about the role of research?
Well, I'm a researcher, so I'm all about research, and I would say anything that I do, I connect research to. Research is a way to show and to demonstrate that it happened and what you're doing has an effect. So I'm also very biased because I'm a researcher. But everything that I'm doing in terms of patient navigation and peer support, I add a research component to.
But you're biased in the direction of research, not...
Yes,
right.
Bias in the context of I love research.
Right,
Yes.
That's the bias.
Yes, that's my bias. I love doing research, yes.
What do you think, Michelle?
And I think in the online community, I think that is an emerging body of literature. And peer support we know quite a bit about, but the online space is emerging. I am asked to do different types of studies all of the time, as my colleagues are as well. I think that we need more researchers in this space, and I think that one of the more interesting, I think, things that has happened lately is there's something called iDocker, which is the Intercultural Diabetes Online Community that was put together by some colleagues of mine. And Anna and I have been fortunate enough to be a part of that as being on the advisory board. And what that is researchers working with people in the diabetes online community and also diabetes educators in trying to understand what research should be developed in this space. And it's really nice to see that there's this community participation in how research is designed. We call this co-design. And I think that that's how you get research done right. I mean, I think that researchers can make assumptions about things and try to design a research that hopefully works. But when you involve patients and even educators, I think that you can actually develop something much stronger and more feasible, really. I mean, we need to make sure that people want to participate in research. And so I think it's also co-designing with patients. And if you think about, back to the clinical side, we have a lot of patient advisory panels that help guide how we run clinical care. And that's critical in research as well.
Yeah, and we've just started to delve a little bit into research with iDocker, but couple of years ago, 2 years ago, we worked with Johns Hopkins and the University of North Carolina at Chapel Hill to do an online study online forum asking women what are the most pressing research questions that they have. Just to help drive that research in diabetes with women. So we got a lot of different things, and the paper is up on our website on diabetessisters.org. But what was very interesting was women are interested in learning about diabetes and complications, diabetes and cardiovascular disease, but they also wanted to talk about that social aspect, right? They wanted to talk about diabetic tattoos or wearing diabetes jewelry. So those kinds of things. They wanted to talk about intimacy. They wanted to talk about menopause. There's no research. There's hardly any research on diabetes and menopause. And women with diabetes are getting older. We're getting older.
Yeah. It's relevant.
And our endocrinologists don't know what to tell us. Right? Our OBGYNs, they don't know what to tell us about how to manage blood sugar when we're nearing certain ages. Yes. So the research is so important across lifespans. Michelle and I were talking yesterday about motherhood. There's not a lot of research about parenting with diabetes.
Yes.
Right? There's a lot of research about diabetes and pregnancy.
And where your A1C needs to be, those tight A1Cs during pregnancy.
But what happens after? What happens during the 4th trimester? Right? What happens to us physically and emotionally, mentally? So it's so important so that research is there, and then as patient organizations, we can go back and share that with our communities.
Right.
Yeah, along those lines, this is something that I think maybe we've had conversations about, and something that I think a lot about it. When we're doing research, I love doing research, and I'm a firm believer in research. I've said this several times. But not everybody understands the value of research, okay? And so, for example, when I'm talking and doing community health worker trainings, one of the things that we do is that we do a lesson on the value of research, because one of the things we have to do is we fund community health worker trainings and community health worker programs because we have a grant for community health workers. We only have the grant because we collect data, and then we submit the data to continue to have grant funding. And so it's really important that the community health workers understand that we need to collect this data so that we have research, so that we can submit it, so we can continue to get the funding, right? Because we don't have the perfect healthcare system, and that's not what the panel's about, but it's not a perfect system. So right now the system is we rely a lot on grant funding. And you need to have numbers and research and data in order to continue some of these programs. So for one of the things that's a big challenge for me, and that I'm always trying to convince individuals, is the value of collecting data. And in rural Appalachia, that's one thing that I've struggled, is trying to convince certain individuals of the importance of collecting data and numbers. And it's something I'm still working on myself, to try to share that message of the importance of the value of research and why it is so important that we have this information. So that's one of the barriers, is research.
And it strikes me that's one of the opportunities. If, as a diabetes educator, if you find yourself in that position, I think of diabetes educators as translators, right? We're translating what we know from healthcare research into practical, useful tools that we hope and support the people we know with diabetes to adopt. And I think that translation process of understanding, what is how does research work? What is its value? And how has research informed the latest and greatest approaches we have now, and making that case, but also how can it be helpful down the road, I think is helpful, because there is a whole structure around that that supports what we all do. Well, we're coming to the end of our time. I want to thank this wonderful panel for sharing the morning with us: Anna Norton, Michelle Lichman, and Liz Beverly. We'll leave you with the last thought of keep calm and ask for peer support. Thank you so much for your attention this morning.